viewers, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a case of a subependymal giant cell astrocytoma, or SEGA, in the absence of tuberous sclerosis. So this is a case of an 11-year-old girl who presented with unsteady gait and impaired vision, and on examination was found to have papilledema. The MRI showed right lateral ventricular tumor extending into the foramen of Monroe, and she underwent resection of the tumor. And as you can see here from the low power magnification, as if the tumor is biphasic, cellular areas alternating with hypocellular fibrillary areas. This is very important clue to the diagnosis. The other tumor that might give some resemblance to this is ependymoma. So cellular areas with large cells with abundant acidophilic cytoplasm alternating with areas that are so fibrillary. On higher power magnification, the cellular areas here and their abundance of fibrillarity in the background. Now the cells themselves have this abundant glassy acidophilic cytoplasm, the eccentric nucleus, sometimes with the prominent nucleolus, giving some resemblance to ganglion cells. Important clue that these are not ganglion cells, that we do not see any nissl substance at the periphery of the tumor. Now, some tumor cells might be smaller with some spindling or even barely minimal amount of cytoplasm. These are all tumor cells, but the characteristic tumors are genistiocyte-like tumor cells with the abundant acidophilic cytoplasm that is a glassy, having this glassy appearance, and then the tendency sometimes to align themselves around the vessels, again in this cellular or nuclear fibrillary zones, giving some resemblance to ependymoma. And another area where we have those glassy cytoplasm abundant cells with the prominent nucleolus in a nucleus that is eccentric, but remember, we do not see the granular basophilic nissl substance that is very characteristic of ganglion cells that would really resemble these tumor cells. So remember, whenever you encounter this type of a tumor, the location is extremely important in the lateral ventricle, if frequently extending into the foramen of Monroe. These are frequent occurrences, then you have to think of SEGA. And of course, we have the fibrillarity, abundance of fibrillarity in the background. And the most important immunohistochemical stain is GFAP, which is strongly diffusely positive in the fibrillary zones as well as in the cytoplasm of each and every tumor cell, as well as number 2, coupled with GFAP, is positivity for S100, which you can see it in the fibrillary background as well as in the tumor cells. And more recently, what has been described is the TTF1 nuclear staining in the in those giant cells of the SEGA or of the subependymal giant cell astrocytoma. These 3 immunohistochemical stains are typical of the SEGA, and they should help you, in addition, of course, to the radiological findings, the location of the tumor, as well as the H&E, to establish and reach out into the final diagnosis. Now, Chi-67 is usually extremely low, less than 3%, in this case around 1%, because this is a WHO grade 1 tumor. So the final diagnosis in this case is a SEGA, subependymal giant cell astrocytoma, CNS WHO grade 1. Of course, most of SEGA cases are described in association with tuberous sclerosis, and the patient underwent genetic testing and the case was negative. So this patient does not have any of the features features of the SEGA, the skin manifestations, the other tumors in the brain. She's a smart little girl with no history of seizure or any effect on the IQ of the patient. When you look into literature, and I have a caption to a recent article published in 2024 of a number of cases now in literature, 48 cases in which SEGA is described without association with the tuberous sclerosis. What is really important to know is that the morphological features are exactly the same, whether this is associated with or not. Without SEGA, the immunohistochemical features are the same. And if the patient or the tumor progresses, they can respond to mTOR inhibitors exactly like patients with the diagnosis of SEGA, of tuberous sclerosis. Of course, this has important implications for the patient and the family, because if the patient is diagnosed with this tuberous sclerosis, then she has to undergo surveillance as well as genetic testing and counseling for the rest of the family members. And remember, sometimes you might be challenged if you make such a diagnosis without the history of a tuberous sclerosis. But remember the triple immunohistochemical profile, the GFAP positivity, S100 positivity, and TTF1 positivity in the right clinical, radiological, and morphological context can help to support your diagnosis. I hope you find this tip useful in your daily practice. Thank you.